This is the first part of my video cast on keywords related to anatomy in the generic clinical section of the in-training exam. Additional relevant information can be found in the video cast on lung ultrasound. These are the keywords on this subject which have been used over the last several years. This video cast will focus on ultrasound anatomy. One type of question would address the general anatomy of the neck. My impression is that the questions are less likely to focus on the muscles of the neck and more likely to focus on vascular and airway structures, so those are the things I will address in this video cast. This article from 20 years ago documents that in most patients the internal jugular vein overlaps the carotid artery to some degree. In fact, although the precise distribution changes with age, the most common anatomic relationship in every age group is that there is a 75% overlap between the two. This image shows substantial overlap of the carotid by the IJ. In this circumstance, however, there is no overlap. The presence of pulsations has been recommended as a way to differentiate the jugular from the carotid. But as this video clip shows, the IJ may have pulsations. Although not applicable for patients under general anesthesia, distension occurring with the Valsalva maneuver has also been recommended as a differentiating feature. Color flow Doppler is another technique advocated to differentiate between the carotid and the internal jugular. This formula describes the Doppler shift. You don't have to worry about remembering the formula. Recognize that there are 5 factors in the formula. However, once you have selected your probe, the only factor you can control is the angle of the probe in relation to blood flow, that is, the angle of inclination. The angle of inclination is the angle between the beam and the direction of blood flow. By convention, most color Doppler applications are configured such that blood flow away from the probe appears blue and blood flow toward the probe appears red. That leads to the acronym BART, blue away, red toward. It's important to understand the ramifications of this. In this example, with the blood flowing toward the probe, the flow in the vessel will appear red, red toward. In this example, the vessel hasn't changed and blood flow is still right to left, but now, because the flow is away from the probe, the blood flow will appear blue, blue away. One more thing about color Doppler, although it's unlikely to appear on the exam, is to realize that the cosine of a 90-degree angle is 0. This means that if the ultrasound beam is perpendicular to the direction of flow, it will not be able to detect the velocity of flow, so no colors will be displayed. A couple of things to notice about this scan. First, notice the color bar on the left side as you face the screen. This shows the range of velocities from plus 16 centimeters per second to minus 16 centimeters per second. It also shows that flow toward the transducer, flow between 0 and 16 centimeters per second, will show as various shades of red, while flow away from the transducer between 0 and minus 16 centimeters per second will show as various shades of blue. This is the usual convention, blue away, red towards. Here's another image of exactly the same vessels. The only difference is that the angle of the probe has been changed. Note specifically that the color bar on the left is unchanged. Most, if not all, ultrasound machines have the option to invert this color arrangement such that blue is toward the transducer and red is away from the transducer. Given the fact that the colors of the flow can be changed, you have to be able to differentiate the artery from the vein based not only on the color, but also on the angle of inclination. As was previously discussed, pulsatility is not a reliable way to differentiate the carotid from the IJ because this video clip shows that both of the vessels have some pulsatility to blood flow. Several other things to take into account include the thickness of the vessel walls — arteries have thicker walls than veins — and the compressibility of the vessel. Compressibility is probably the most reliable way to differentiate between an artery and a vein. Slight pressure of the probe will cause compression of the internal jugular vein. Note that although the diameter of the internal jugular is decreased, the size of the carotid artery remains essentially unchanged. It should be noted, however, that excessive pressure can result in compression of both the artery and the vein. There are essentially two different ways to use ultrasound guidance for placement of a central line. The dynamic technique involves using the probe real-time as the line is inserted. The static technique simply uses the ultrasound probe to confirm the position and patency of the target vessel. After those have been confirmed, the probe is no longer used. Here's an ultrasound image of the vessels in the longitudinal axis, demonstrating a thrombus in the internal jugular vein. As noted, the presence of the thrombus results in the jugular not responding to external pressure from the probe. Here's another image demonstrating the presence of a thrombus in the internal jugular vein, but this time it is visualized in the short axis. More subtle, and not filling the entire diameter of the internal jugular vein, a thrombus is still visualized in that vessel. Ultrasound can also detect the presence of valves in the internal jugular or other veins. The second general area of ultrasound anatomy of the neck relates to airway anatomy, either identifying the cricothyroid membrane or for the purposes of confirming tracheal intubation. This ultrasound image shows a normal larynx. You can see the thyroid cartilage, which appears as a hyperechoic inverted V. The hyperechoic vocal cords are also an inverted V. The arytenoids, which appear as lumps at the base of the vocal cords, are also visible. Although it's unlikely to appear on the test, you should probably be aware that ultrasound has been used to guide the tracheal tube in cases of difficult intubation. In this case report, one person manipulated the probe while the second person watched the screen and used the information displayed there to guide the tube into the trachea. Here's a transverse view of the neck. You can see the trachea, thyroid gland, the carotid artery, and the internal jugular vein. Notice that the esophagus, indicated by the arrow, is to the left of the trachea, which calls into question the efficacy of cricoid pressure in preventing regurgitation. One reason to look at ultrasound anatomy of the neck is to confirm correct positioning of a tracheal tube. Here's a different transverse view of the neck. For our purposes, we are primarily interested in the trachea, esophagus, which is located to the left and partially behind the trachea in this view. This is a static image of a tracheal tube in the trachea. The trachea is identified by the letter T, while the esophagus is identified by an E. The image shows the trachea containing two hyperechoic lines. It also shows what has been described as the bullet sign, which displays a more rounded view of the anterior portion of the trachea and increased posterior acoustic shadowing. This image shows an esophageal intubation. Note the second air mucosal interface in the esophagus, as indicated by the arrows. In addition, the esophagus is more rounded as a result of the incorrectly positioned tracheal tube. The combination of the second air mucosa interface and the rounded presentation of the esophagus results in the so-called double trachea sign. Here's another example of the double trachea sign, with the structures highlighted in colors. Notice that with the tracheal tube in the esophagus, it becomes more round and strongly resembles the trachea. Finally, here's a side-by-side comparison of images from a tracheal intubation and an esophageal intubation. The key points for differentiation of a tracheal tube placement are as follows. The tracheal intubation shows a single air mucosal interface representing the trachea, as shown by the red arrow. Second, there are two hyperechoic reverberation artifacts in the trachea, representing the tracheal tube. Finally, there is the bullet sign. In contrast, if the tube is in the esophagus, there should be two air mucosal interfaces, one for the trachea, as indicated by the red arrow, and the other for the esophagus, as indicated by the blue arrow. Furthermore, the rounded, dilated esophagus results in what's known as the double trachea sign. The final section will address ultrasound to determine the position of the cricothyroid membrane. Here's a longitudinal view of the trachea with the structures overlaid with colors. The primary reason this is of interest to us as anesthesiologists is to be able to identify the cricothyroid membrane. That structure is important if you're going to perform a transtracheal injection to provide anesthesia to the subglottic trachea during an awake intubation. It's also useful if you had to perform a transtracheal jet ventilation. If I were writing a question on this subject, I would probably have an image of the trachea with letters marking the thyroid cartilage, the cricothyroid membrane, the cricoid cartilage, and the space between the cricoid cartilage and the first tracheal ring. I would then ask which of these locations would be the best site to perform a transtracheal block or a transtracheal jet ventilation. The image shows the hyperechoic thyroid cartilage and cricoid cartilage. A hyperechoic line between the two is the cricothyroid membrane, here shown as an orange stripe. The series of hypoechoic structures to the right of the cricoid cartilage is a so-called string of pearls, which represents the tracheal cartilages. The blue line below the cricoid and tracheal cartilages is the air tissue interface. Reverberation artifacts, analogous to A-lines in lung ultrasound, may be seen below the air tissue interface. Here's the long axis view of the trachea unobscured by colors. The hypoechoic areas labeled A represent the tracheal cartilages. The hypoechoic area designated B is the cricoid cartilage. Notice that it is larger than the tracheal cartilages. While not as clearly visualized as the others, C is the thyroid cartilage. Obviously, the area between the thyroid and cricoid cartilages is the cricothyroid membrane. To summarize, ultrasound is used to facilitate cannulation of the internal jugular vein. The IJ commonly overlies the carotid artery. Although color flow Doppler is sometimes recommended to distinguish the carotid from the IJ, the angle of insonation and the color map will impact the colors displayed. Since the jugular vein may have venous pulsations, relying on the absence of pulsations to distinguish the IJ is not reliable. The most reliable method of identifying the IJ is determined compressibility. Gentle pressure with the ultrasound probe should result in compression of the vein, but not the artery. Excessive pressure may result in compression of both. Finally, ultrasound may identify the presence of a thrombus or valves in the vessels. Multiple articles have described the use of ultrasound to confirm position of the tracheal tube in the trachea. Most articles describe a static image obtained in the transverse plane, but a few describe dynamic imaging. Probably the most reliable indicators of an esophageal intubation are the absence of lung sliding on both lungs during a positive pressure breath and the appearance of the double trachea sign. Ultrasound may also be used to localize the cricothyroid membrane, either before a cricothyroidotomy or before a transtracheal injection of local anesthetic. Placing a needle between the probe and the skin overlying the cricothyroid membrane permits marking the location. Thank you. This is the end of this part of generic clinical anatomy. I hope you found it helpful.